Hello people. So this is a video about frozen shoulder or adhesive capsulitis. But before we talk about frozen shoulder, it is better to see the key elements of the anatomy of the shoulder. Basically, what are the key structures that stabilize and move the shoulder? Once we know and can take these apart, it is easy to understand what happens in frozen shoulder. Even though the pathophysiology of frozen shoulder or adhesive capsulitis, as it is also called, it is not completely understood. So the shoulder joint is actually a ball and socket joint. The ball is the humeral head, so this is the ball of the joint, and the socket is the glenoid fossa. So we can see that the glenoid fossa is very shallow, and it is only extended with fibrous tissue that is called the glenoid labrum. Even with these extensions, the glenoid fossa is a very shallow socket, and the head of the humerus is a bigger ball. This tells you that this joint is made to have a high range of movements, and it is stabilized by the capsule of the joint, by different tendons of different muscles, and also by the rotator cuff muscles. Like one of those muscles is the supraspinatus muscle, and also by muscles that are more superficial, like the deltoid muscle. First of all, we will see what muscles make up the rotator cuff, because the rotator cuff is very important for stabilizing the shoulder joint and also for enabling high ranges of movement. The rotator cuff is made up of 4 muscles. If we look from the back, so this is when we look at someone's back and take off the skin, we would see this. This is the scapula and this is the humerus. So the scapula and the humerus. On the back side of the scapula, there is this bony prominence called the spine of the scapula, and above the spine of the scapula is a fossa called the supraspinous fossa. And in this fossa, there is the origin of the muscle body of the supraspinatus muscle. So this is the origin of the supraspinatus muscle, and the tendon of the muscle goes and attaches on the greater tubercle of the humerus. So this is the greater tubercle of the humerus, and on its superior part, here is the attachment of the supraspinatus muscle. So you can imagine when the supraspinatus muscle body contracts and pulls here, the humerus will be going this way. So it will be going up and away from the body. This is why the supraspinatus is an important muscle for abduction. The abduction of the humerus of the arm from the body. It is abducting, moving away the arm from the body. And it is logical once you know the origin and the attachment point. So this is the first. Then we have in the inferior to the spine of the scapula, in the infraspinous fossa, we have the muscle that is called the infraspinatus and the muscle that is called the teres minor. So the teres minor, and this is for the infraspinatus muscle. These two muscles have their muscle bodies and origin so in the infraspinous fossa, and their tendons also attach at the greater tubercle of the humerus, of the humeral head, but they attach in the middle. The infraspinatus attaches in the middle part and the teres minor in the lower part. And these two muscles, so the infraspinatus tendon that is above and the teres minor tendon that is underneath it, you can see this is the back of the humeral head. When these muscles contract, they are rotating the humeral head to the back. That means the whole arm will be rotated externally. So these two muscles are important for external rotation. Then we have, so these are two more muscles from the rotator cuff. And we have the last but not least, the subscapularis muscle. So if we look from the front, if we remove the rib cage, this is the front part of the scapula, and this is called the subscapular fossa. And there we have this big muscle called the subscapularis. This is the fourth and the last muscle that makes up the rotator cuff, the subscapularis. The muscle body is originating here, and it is attaching here on the lesser tubercle. So it is on the attachment point, it is on the lesser tubercle. And you can imagine, once the muscle contracts, it will rotate the humeral head inward. This will contribute, this will move the arm, it will rotate the arm inwards. So internal rotation is the movement that the subscapularis does. And here we see also, this is the superior part of the greater tubercle where the tendon of the supraspinatus attaches, that is important for abduction. Together, these four muscles make a cuff around the humeral head that is rotating it. Hence it is called the rotator cuff. And it is very important for stabilization and movement of the humeral head. Now we will look at the key part to actually understanding the entity known as frozen shoulder. So in frozen shoulder, there is actually a limitation of range of movement, and in some part of the disease, the movement is severely restricted. So why does this restriction happen? In the core, we don't know the core pathophysiology, but we know some elements. The important one important element of that stabilizes the glenohumeral joint, so the shoulder joint, is the joint capsule and the ligaments involved in it. So here is this the shoulder joint with some other ligaments, and we see that here we have the joint capsule. The important ligaments for the pathology of frozen shoulder is a ligament that is going from the scapula. The scapula has this bony prominence called the coracoid process, and from the tip of it we have this ligament This ligament is called the coracohumeral ligament. So the coracohumeral ligament thickens and becomes more fibrous in frozen shoulder. Also, we have ligaments that are connecting the neck of the scapula, that is here, and the anatomical neck of the humerus, that is here. So these ligaments are called glenohumeral ligaments. We have the superior, the middle, and the inferior. And the middle one, especially the middle, so the middle glenohumeral ligament also is one of the ligaments that thickens in frozen shoulder. So this is when we look at the shoulder from the front. So we see this is the lesser tubercle, this is the greater tubercle. Here is the bicipital groove between the tubercles where we have the tendon of the long head of the biceps that is also a stabilizer of the shoulder joint. But for this purpose, the important thing is the capsule, the anterior capsule especially, the coracohumeral ligament that is going from the coracoid process to the humeral head, and the glenohumeral ligament that is going from the neck of the scapular to the anatomical neck of the humerus. So the thing that is happening, and this is proven, people did arthroscopies, so they went with cameras into the joint and looked what happens with the synovium and what happens with the capsula macroscopically, and also took samples for pathological analysis. They found out that in the early stages of the disease, when we have much pain, there is synovitis. The synovium is inflamed. And as the disease progresses, as the shoulder freezes up, the anterior capsule especially, and the coracohumeral and glenohumeral ligaments, especially the middle one, they become more hypercellular and more collagenous, and they thicken up. So this is the main thing why this part of the shoulder becomes more immobilized. And you can imagine that all movements are restricted, but especially external rotation. And why is that? So when the anterior part of the shoulder gets thickened up, the muscles, the infraspinatus and the teres minor that are responsible for external rotation will have a hard time trying to rotate the shoulder externally. And even though all movements because of this are restricted, external rotation will be especially emphasized. So now we will see the stages of the disease. So the disease actually has 4 stages. This is so the shoulder area. The shoulder is obviously covered up by bigger muscles like the deltoid. The adhesive capsulitis is a disease, or also popularly called a frozen shoulder, because the shoulder basically freezes up, is a disease that has a prevalence about 2% in the population, more in diabetes mellitus, 10 to 20%. We don't know really why. It is more frequent in the ages from 40 to 60 years of life, and it is mostly a self-limiting condition. It can last up to 2.5 years, and we will see why. So the 4 stages can last long, and it can make up 2.5 years, but in the end, it will be a self-limiting disease. But In some cases, residual contracture and loss of range of motion of movement in the shoulder can be a complication of the disease. So typically it is divided into primary adhesive capsulitis and secondary, and it is easily to distinguish that secondary happens after trauma, surgery, and so on. So it is a secondary complication after another disease. And the primary disease is idiopathic. And that means we don't really know why it happens. The underlying pathophysiology is unknown. The idiopathic and secondary, all of these frozen shoulder pathologies have two main characteristics, and those are pain and contracture. So all patients will have pain in the shoulder area, and they will also have contracture. So the range of motion will be limited, and this is especially true in external rotation, and I explained why. So the patient will not be able to easily do an external rotation, and he will have significant pain in the shoulder area. This is the disease. Actually, in order to diagnose this disease, the main thing is a detailed history and a detailed clinical evaluation with laboratory and X-ray pictures in order to rule out other conditions. The disease has 4 stages. So stage 1 is actually called the stage of synovitis. So in stage 1, this is the stage that lasts from 0 to somewhere between 3 months, the first stage. The main symptom is pain. So because of the synovitis that is developing, we have more pain. The range of motion is not really restricted. It can be restricted by pain, but the capsule is at that time still normal. There are no changes. Then we have stage 2. Stage 2 is the so-called freezing stage. This stage lasts somewhere between 3 to 9 months. So between 3 to 9 months. And in this stage, so the second stage, the shoulder, there are changes in the capsule. So there is fibroplasia of the capsule of the joint, and there is loss of movement. So there is loss of movement in the second stage. In stage 3, which is called the frozen stage, it can last from 9 to 14 months. So from 9 to 14 months. In this stage, there is the joint is stiff, the range of motion is limited, but the pain is less. So the synovium is thickened, dense, and also the capsule is dense and more collagenous and hypercellular. The last stage, or the fourth stage, is actually called the thawing stage. It can last from 15 to 24 months. In this stage, we have recovery. So the pain is progressively becoming less and less, and we have progressive increase in range of movement. So in the light of that, if we have a patient that is developing like this, and if we, for example, take a detailed history and evaluate the clinically the patient and see this, and if we don't have labs and x-rays that are pointing into another direction, then we can say this could be adhesive capsulitis or frozen shoulder. If we are not sure, we can also do ultrasound, and rarely, if it is needed, MRI. So on ultrasound and especially on MRI, if we found anterior capsule thickening and the thickening of these ligaments, then this talks into the diagnosis of frozen shoulder. The treatment for frozen shoulder, so basically it is a self-limiting disease, but because there could be complications once the disease passes in limitation and contracture, limitation of movement and contracture, we should treat this disease with pain medication. So NSAIDs will do it, and we should also do a physio or physical therapy. So physical therapy protocols are developed for this disease, and they will make sure that only a small amount of patients will in the end have some kind of contracture. Also, when we have significant symptoms, pain and so on, we can do intra-articular injections with corticosteroids. And really, in hardcore cases, there is a possibility for operative treatment, and operative treatment is basically arthroscopically with small cameras. There is capsular surgeons do a capsular release of the joint. So basically, this is a self-limiting disease that is diagnosed mostly by history taking and clinical analysis. But even though it is self-limiting, it can last 4 years, and it can leave some problems in shoulder movement restrictions. Thank you.